Hello, I'm Dr. Meghan Davis, and I'd like to talk about chemical, physical, and biological exposures from both an environmental health and occupational health context. The environmental health paradigm, otherwise known as the toxicological paradigm, is a framework we use to understand how exposures cause disease. And in particular, we try to use this framework as a way to understand how to reduce exposure or prevent disease in order to improve the health of the public. In the environmental health or toxicological paradigm, we consider how exposure on the outside of a person might be internalized and measured as internal dose. It might further be measured as the biologically effective dose at the cellular level, specifically at whatever target is appropriate for that agent, to result in early biological effects or changes, again at the molecular or cellular level. These then ultimately can result in altered structure and function, for example, of organ systems or other systems in the body that will manifest as clinical disease. When we think about the toxicological paradigm, the toxicology part comes from this piece from internal dose through altered structure and function. It's the pathophysiology of how agents cause disease. You might also consider this stepping back from an epidemiologic perspective, looking at data and associations between exposures and disease outcomes. Within this, we consider there are effect modifiers and susceptibility factors that can influence how exposure results in clinical disease. Effect modifiers might include things like diet, habits, medications, co-exposures. Susceptibility factors could be biologic, for example, genetic polymorphisms that increase or decrease susceptibility along this pathway. Ultimately, when we consider the route from exposure to clinical disease, there may be many different kinds of exposures, and they may result in differences in terms of the pathophysiology. So let's talk about some of these different kinds of exposures. Physical agents include noise or radiation. And one example of this is the Chernobyl incident in 1986. So here I have some images from a colleague of mine showing the site at Chernobyl where there was the nuclear meltdown. And you can see in the picture on the left, the dome that has been placed over the site in order to prevent further exposures. Radiation can take many different types. These can include radon, which are alpha rays, and these are composed of 2 protons and 2 neutrons, and they result in ionized energy, but they're very short range. And so radon as an exposure typically is a problem primarily with inhalation. And so this would be, for example, if there is radon in the basement of a house and someone breathes in the alpha rays, then there's really no barrier between the lungs and the alpha rays, and that can then result in damage. But when radon has to travel over larger distances, it can be stopped by something as simple as paper, and therefore does not have problems in terms of what we might typically think about from like nuclear radiation, which is comprised of beta or gamma rays. And these can penetrate paper, and gamma rays can penetrate even aluminum and other kinds of elements, and can only be stopped by things a little bit thicker like lead. This is also true with medical imaging, if we're thinking about X-rays, where people might wear lead as personal protective equipment to help stop the radiation. Then there might also be neutron rays that can even penetrate lead. So if we look at the toxicological paradigm and we consider ionizing radiation as the exposure, the internal dose would be radiation in the body. At the target site, radiation would impact rapidly dividing cells. Some of the most rapidly dividing cells in the body include in the gastrointestinal tract and in the immune system. And so damage within these can result in gastrointestinal and immune disease. And this can manifest in terms of radiation sickness. And so what you see in the image is the location of the Chernobyl site and some of the exposures in terms of the way the plume went. If we consider a toxicant example, one of these could be the 1950s events that included the London fog. So this is when there was inversion and a lot of discharge of particulate matter, or PM, from industrial sources that led to concentration of that particulate matter at the ground level. It looked like fog. If we plot this out in December of 1952, when one of the biggest events occurred, you can see that on the y-axis, you have the pollutant concentration in milligrams per meter cubed. This is on the left-hand y-axis. And on the right-hand y-axis, we have the deaths per day on a scale of 0 to 1,000. The actual days in December of 1952 are graphed on the x-axis. So you have the deaths per day oriented to the right-hand y-axis in maroon. And on the left-hand axis, we have two different kinds of pollutants. You have smoke, which would be total suspended particles, a measure of particulate matter, and another pollutant that also was discharged as part of these industrial emissions, and that is sulfur dioxide. So you can see that by December 4th, you start to see the rise in the pollution concentrations. And then you see a concurrent but slightly lagged rise in deaths. So there was a certain number of expected deaths per day. And you can see that by December 14th, even when the pollutant concentrations had returned to normal, there were still excess deaths per day, represented by the difference between the baseline number of deaths per day and the post-event number of deaths per day. This makes sense from a biological perspective because both PM and sulfur dioxide can have effects on the cardiopulmonary system, resulting in respiratory and cardiac disease. And these may not manifest immediately. They can take a little bit of time before you might see someone succumb from effects of these organ system changes. If we plot this on the toxicological paradigm, you see that you might have PM 2.5. So this is particulate matter of a size fraction of 2.5 microns or smaller, able to penetrate all the way down to the alveoli as your exposure. The actual PM 2.5 that is breathed into those alveoli might be the respired PM and the PM in the alveoli, representing the internal dose and the dose at that target, those very delicate tissues within the lung around the alveoli. This would result in inflammation of those cells that ultimately manifests as airway changes and therefore contribute to respiratory symptoms and further disease related to the lack of function of the lungs, which are to breathe, right? Bring in oxygen and discharge carbon dioxide. So on the left, you can see a graphic that shows the size of PM 2.5 compared to other typical things that you might think about, like human hair or fine beach sand. So these are teeny tiny and they can go very deep in the lungs. And that's part of how they cause disease. For a biological exposure, I'll use methicillin-resistant Staphylococcus aureus, or MRSA. MRSA is one of the most commonly identified antibiotic-resistant pathogens globally. And in the United States, we recognize that the NHANES estimate for nasal colonization might be 28%, or a third of the population, for the susceptible form of Staph aureus, and a smaller percent for the antibiotic-resistant form. There are certain subpopulations that have much higher MRSA rates, and these can include incarcerated populations. People in schools actually can have slightly higher rates of MRSA, and in healthcare settings. This bacterium colonizes the nose, the nasal cavity, and as a result can be distributed to skin sites. And so some of the most common places to measure it are in nasal swabs, in swabs of the throat, and swabs of skin folds. It also lasts a very long time in the environment. So if Staphylococcus aureus is shed into an environment, it can persist for weeks or months. And this plays a role in re-exposure of people. And so you might consider the environmental Staphylococcus aureus as the exposure, colonization as the internal dose, Staph aureus at an injury site and infected skin cells as the cellular mechanism, Changes such as a formation of abscess contributing to a soft tissue infection. And I have an image of a not so bad skin or soft tissue infection on the left. When we're thinking about exposures, a lot of times we want to look upstream, not just at the point at which a person is exposed, but what the sources of those exposure are and how those sources reach a person through which environmental media. In terms of environmental media, we typically think about air, water, food, and soil or dust. And we recognize that these may be mediated through the built environment. So, for example, a building and its ventilation characteristics might mediate how exposure in the air contributes to exposure of the person. An example of this could be an area where there have been wildfires and wildfire smoke has come into the area and is outside of a building. But based on the ventilation characteristics of the building, a lot of that PM of various size fractions coming from the wildfire smoke might not contribute or infiltrate into the spaces within the building. And so the exposure a person inside the building experiences will be quite different than the exposure a person outside the building faces. So how are we exposed? I work a lot with farmers. So here I have an image of a farmer. And so I might think about airborne exposures would be contributing to upper and lower respiratory tract exposure. So this could influence the lungs. If there's water, that can be something ingested and could therefore influence the gastrointestinal tract. But there might also be skin contact. Certainly, we think about the psychosocial environment as being much larger, related to all of the various social determinants of health that can influence a person. On the right, we have both direct and indirect exposures from animals, hence I picked a farmer. And so you might have direct contact with animals through the skin, and also indirectly, potentially through food, if these are food-producing animals that might be ingested and therefore influence the GI tract. Finally, I work a lot with dust in terms of household dust in particular, and this can influence the respiratory tract, the GI tract, and the skin. So if we think about the toxicological paradigm or the environmental health paradigm as being the component on the right, how exposure contributes to health effects and may be modified by different factors, including susceptibility factors, we might go upstream and think about the agents or the hazards and their various routes of exposure. But ultimately, our goal is to understand risks associated with these exposures and then manage them. And so the management may be more on the source side. It may either focus on elimination of the source or identification of the routes in order to reduce exposure and therefore prevent disease. So we come back to our different kinds of exposures. These can include our physical exposures, our chemical exposures, and these biological exposures. They also extend to ergonomic issues, safety concerns, social factors, and psychosocial factors. And so they can influence not just cells from this direct level. You think about what radiation does to a cell or what chemicals or biological agents can do to a cell, but also other factors that can influence hormonal axes and stress systems within the body. And then we consider how we're exposed to these agents: inhalation through breathing, absorption through skin contact, ingestion would be eating, and injection. One of the things that we try to do is understand how we measure these exposures. This contributes to how we assess risks, understand if they are above or below a potential threshold where we might need to take action or not. We think a lot about duration, concentration, and frequency. Duration is how long does the exposure last? Is it all the time? Is it something quite limited? The concentration, how high was the exposure? And the frequency, if the exposure recurs, how often does it recur? This is often easiest to do within occupational cohorts or workers because some of them may be exposed at higher concentrations. Here I have an image of the radium girls at Ingersoll factory who famously used radium or radium-based paint in order to make the hands of a watch or a clock glow in the dark. And they did very meticulous work where they would take this paint and paint it on to the face of the clock. Some of them would lick the brush in order to get the tip very fine because this was very detailed work. Some of them would also enjoy painting themselves because they would then glow in the dark. And so the exposures could be quite high within this particular cohort before it was recognized the danger that this posed. We also might measure through biomarkers. These are various tissue samples or excretions that might give us a window into what the internal dose or biologically effective dose might be, or might help us understand the early biological effects. And so this can include things like, on the right, saliva or feces, representing the gastrointestinal tract, blood, which might be an integrated sample across many routes of exposure, and through excretion through the kidney, urine samples. You might collect hair or even nail clippings in order to understand certain kinds of exposures. There are biomarkers we can use of exhaled breath that give us a window as to what's happening within the lungs. And finally, although less common, we might look at actual skin samples, such as the microbiome of the skin or sweat samples. So if we place this on the toxicological or environmental health paradigm, you can see how we might look at these different components of internal dose, biologically effective dose, but we may also need to measure our susceptibility factors, for example, genetic polymorphisms, or collect information on effect modifiers, other exposures, different behaviors people have, and their health status. In this, we think about susceptibility as groups of people who might be at particular risk. And so these might be host-related factors that could be biologically related to activities happening at different ages or people of different genders or race and ethnic background. Again, often related to genetic differences or other differences in terms of the way they may process or respond to various agents. But there can also be extrinsic or exposure-related factors, such as nutritional status, geographic location, socioeconomic status, or other comorbidities, diseases that could influence the way an agent might respond within a body. For example, someone with kidney disease may have limited ability to excrete certain chemicals, and that could lead to either more or less excretion of an agent from the body, influencing its toxicokinetics or toxicodynamics. With behavior, there are many different kinds of co-exposures that could influence this relation between the environment and the exposure and the ultimate disease outcome. So, for example, with activity level, someone who has really good respiratory fitness and is exercising a lot may actually get a higher exposure to ambient air pollution than someone who is less physically active. Because they're often active outside, they have an increased tidal volume, they're breathing in more air and at an increased rate. And this can paradoxically increase their dose. Lifestyle can also be important. Where you live, urban, suburban, or rural settings often have different kinds of ambient exposures. And then there may be concurrent exposures. For example, if someone smokes or is exposed to environmental tobacco smoke, that could contribute to respiratory irritation, and that could change the barrier function of the respiratory tract in terms of its ability to withstand, for example, biological or infectious agents. We certainly noticed that in some data from the COVID-19 pandemic, where there were some associations between ambient PM air pollution and rates of or case rates of COVID-19. Finally, occupation can be very important and often is not considered as explicitly within our electronic health record systems and medical services. And so it's something to pay close attention to. Within workforces, there's something known as a healthy worker effect. In this, we recognize that workers appear to be less susceptible to disease than the general population, despite often having higher specific exposures to agents that may be used at the work site. The reason for this is that people who have comorbidities or are vulnerable in other ways, we don't have infants working, and there are certainly older people who no longer are able to work, who are selected out of this group. And so the ones who are left are typically, on average, a little bit more healthy. And this is a form of selection bias. Ultimately, our goal is to reduce exposure in order to prevent manifestation of clinical disease. And so let's think about those interventions. There are many different protective behaviors that may be used. I think given the global experience of the COVID-19 pandemic, we understand personal protective equipment or PPE in a different way than pre-pandemic. The use of masks globally has increased a lot. People recognize the potential routes of exposure through droplet, aerosol, or contact-based transmission. So there may be things that people do in addition to use of PPE that can help protect. And so again, using the SARS-CoV-2 example, vaccination and social distancing are behaviors and as well as interventions that may reduce exposure or reduce the influence of exposure on ultimately disease manifestation. There also may be source exposure reduction or elimination measures. In some infectious diseases, that might include targeting a vector, like mosquito control for West Nile virus, as one example, or eradicating a disease entirely, such as smallpox, or in the animal health community, the eradication of rinderpest. For occupational health, the National Institute of Occupational Safety and Health has delineated what interventions are more likely to be effective versus least likely to be effective using a framework called the hierarchy of controls. In this, you see a color ramp on the left showing most effective to least effective and the various activities that might happen. And so use of PPE is considered least effective because it depends on compliance with the recommendation. So people have to actually put on the mask and put on the mask properly, maybe use the proper mask in order to prevent the exposure from resulting in disease. Slightly more effective than that are administrative controls. This is changing the way people work in order to reduce their exposure to the hazard. So this could mean for SARS-CoV-2 or COVID-19, changing pathways that people take within a workplace in order to have them move in the same direction so they're better able to social distance. Or it could mean having people who don't need to work with a harmful agent working in a different part of the building than the activities where that harmful agent is being used. When you can't get around that, you might have engineering controls. This might be ventilation, through hoods or other built-in systems within a factory that help to isolate people from the hazard. This means that they may be working with it, but there are things that help keep that hazard away from them. I experienced this when working in my own laboratory, where I work in a BSL-2 setting. Biological safety cabinets have special ventilation that pulls air from the outside up into the hood and then out away from the worker who's on the other side of a pane of glass. This helps isolate people from the hazard. More in chemical agent exposures, but elsewhere as well, you might consider substitution. If there is something that is more hazardous, replacing it with something that also works but is less hazardous is a form of substitution. And finally, completely eliminating use of that hazardous agent or physically removing the hazard from the work site. So here I have the application to COVID-19. We've already talked about how PPE, use of masks or respirators, use of gloves are really important, but maybe less effective than administrative controls such as working from home or staggering schedules or using hand hygiene. Changes in ventilation or physical barriers that we saw at many places during the pandemic are forms of engineering controls and are considered more effective than the administrative controls. We can't really substitute SARS-CoV-2, right? It's with us. It's not something that we can necessarily change. Although we are trying different controls through vaccination, and compliance with vaccination would be considered the least effective, but the availability of vaccines would be considered more effective. And then finally, eliminating exposure through social isolation would be considered the most effective. Hence, there were many recommendations to stay at home and sometimes even stay-at-home orders in various countries globally during the pandemic. There are other ways that we can reduce sources, and many of these really target either specific things within a work site or ambient air. And this would be through a variety of standards meant to reduce discharges from various sites, such as industries that have emissions. And these include, for example, in the US, we have the EPA, that sets legally enforceable limit of maximum contaminant levels, or MCLs. This is the maximum concentration of contaminants allowed in drinking water. On the air side, the EPA also has legally enforceable limits through NAAQS, the National Ambient Air Quality Standards. And so it's the same thing, but in ambient air. But there may be other ones that are more advisory or recommendations. And so an example of this is the ATSCR at the Centers for Disease Control and Prevention, which is the Agency for Toxic Substances and Disease Registry, sets advisory levels for the amount of chemicals. And this is related to non-cancer health outcomes and might include minimum risk levels, or MRLs. If we just look at NAAQS from the EPA, considering ambient air, what we have is a figure showing the changes in concentrations of what are called criteria air pollutants from 1990 to 2015. And so what you see is that there are various kinds of exposures, from lead to PM2.5 to NO2, PM10, CO, and various other ones, including ozone and SO2. And so you'll see that most of the NAAQS are on the left-hand y-axis, and lead specifically has its own axis on the right. And these are the percentage above or below the standard. And so what you see is that by and large, these have been effective at exposure reduction. You can see lead concentrations used to be above NAAQS standards and now have come below. And even those that already were below, such as PM10 and NO2, have also decreased over the years.